Hi, everyone. This is John Mandrola with the Heart.org Medscape Cardiology, and I'm here in Madrid, Spain, an ESC meeting, and I'm pleased to have Professor Axel Diederichsen, who is presenting a hotline trial later today called the Dancavas 2 trial. Dancavas 1 was a very important, very interesting screening trial, and Dancavas 2 is also screening. Professor Diederichsen, tell us where you're from and where this trial was conducted.
So I'm from Denmark. I live in Odense, the town where Hans Andersen was from. We did this trial in 18 communities in Denmark.
I'm very interested in the Dancavas set of trials because these are screening trials trying to find heart disease, modify heart disease, and as we know, screening is quite a challenge. Dancavas 1 was a screening trial looking at older adults and a slew of tests, coronary calcium, blood tests, right, EKG recordings. And Dancavas 1, which was published in New England Journal of Medicine, had a 5% reduction in mortality in the invited to screen group. But the upper bound of the hazard ratio was 1.00, and it was declared as not a significant finding. Dancavas 2 how is it different from Dancavas 1?
It is pretty much the same. We invited the same way. We used the CT scanner. We did this blood pressure measurements. We had blood samples exactly the same as in 1. The main difference is the age group. In the Dancavas 1, we invited men from 65 to 74 years. And this time it is men from 60 to 64 years.
And why did you think screening the younger group would be important?
Well, you know that cardiovascular mortality is high. It's the most dominant cause of mortality. So it's a huge importance also among younger men. So we can prevent diseases there. It'll be great.
Tell us about the screening program. I was struck when last time we talked about what it actually is, that it happens after clinic hours, kind of fast and efficient.
Yeah, it was very fast. So we had 5 men an hour, and they first had a signed informed consent, and then we had blood measurements and blood samples and a CT scan. So this was very, very fast and quick, and that's also the way we were managed to do a lot of scans. And we started typically after hours, yeah.
So 5 people per hour can be screened?
Yeah.
So while they're getting the CT scan, they're getting an EKG, and they're getting blood tests beforehand. And
yeah. So the last thing they did, there was the CT scan.
And the CT scan doesn't go to radiology. It's read very quickly.
And that's a very, very important thing. We applied at the committee to do a cardiovascular screening examination. We did not apply to do cancer examination. We not look after anything else than cardiovascular diseases. Then we can ask the technicians to do the readings until the findings had to be examined afterwards. And they approved this.
You can't have an efficient screening program if you're looking at everything. You just need to look at aorta, but basically, and coronary calcium.
Yeah, we did. And also while they were in the scanner, we measured the heart rate.
And the heart rate. How does the randomization work? This is an invitation to screen versus a non-invitation to screen, and this is kind of a provocative or interesting thing.
All men in the age between 60 to 64 years of age, around 30,000 was, living in specific areas in Denmark. So we had all this identified, and then we randomized. Some were invited to a screening, while some were not. And those not invited in the control group, you can say they're not informed about the study. So 1/5 in Dancavas 2 was invited for a screening examination.
And the people not invited are the control arm. They don't know that they're not invited.
They don't know anything about the study.
And they get standard Danish healthcare.
They get standard Danish healthcare.
And then the way you measure outcomes is with the Danish registry.
Yeah, we do that. Yeah.
And which gets pretty much all the outcomes.
Yeah, so in Danish registries we have got, of course, dead or alive, and also a lot of different diseases. In our case, stroke, myocardial infarction, aortic diseases, amputations, revascularizations, and medication, statin, aspirin, antihypertensive treatment, anything you can get from registries. If you ask for and is approved and so on, they can help with that.
And what happened?
We followed these participants for 7 years.
For
7 years. And with 7 years, there was a non-significantly reduced mortality. So again, like the case 1, we did not reduce mortality.
Tell us the actual numbers.
So hazard ratio in Dancavas 1 was 0.95, and this case is 0.94.
So a 6% reduction in mortality,
Yeah.
but
Yeah, so confidence intervals range from a 14% reduced risk to a 3% increased risk.
if the hazard ratio goes to 1.03, it means it's non-significant.
Yeah.
So how do you feel about this?
I'm a researcher, so I'm pleased that we were able to do a study, and I'm pleased to tell you about results, and then others may also come and have their view on it, what I can use this for. Because in this setting, we actually also tried to evaluate the effect of the screening itself. So the study was meant for invited to screening. This is what I can tell you. We did not decrease all-cause mortality. But this time we tried to figure out were there any benefit of the screening itself.
You're studying screening, but you're also studying the invitation to screening, right? Because if you were invited to screening, you might not have got screening. You might not have decided to go.
Oh, that's it. I forgot to mention that. Obviously, if you have a screening explanation and no one will attend, it won't work.
Right.
In our case, 2 or 3 attended. We tried to figure out what would happen if compared those attending with someone not attended but presumably would have attended. Now it's getting more complicated.
In Dancavas 1, you had the same thing. You invite people to screening, and a certain number come, and a certain number don't come. But you never looked at the people who got screened versus the people who didn't get screened, the so-called as treated or as screened, or
Yeah.
Why didn't you look at that?
Because it was so difficult for us. If what are you going to measure? I mean, are you going to measure outcomes of those screened with a control group, or are you going to compare those non-participants with a control group? It gives so weird hazard ratios. It's difficult to interpret these hazard ratios. So we declined. This time we figured out, of course, I would like to know, did the screening explanation itself do any good? I would like to know that as a researcher.
Hey, I want to commend you on never looking at that in Dancavas 1, because obviously the people who sign up for screening are going to be different than the people who get invited and don't screen. In Dancavas 2, you want to know what the effect of the screening is,
Yeah.
but you can't just compare it to the people who don't show up for screening.
No.
What group can you compare it to? And you have to tell me slowly, because this is complicated.
I will try. But I think it's actually a simple equation with a few assumptions.
Okay?
So first of all, we randomize these 30,000 men. Some come to invitation or not. And those invited, we know that 2/3 participate, 1/3 will not. If we had invited the control group, I think it's fair to assume that participation rate would be exactly the same.
Why wouldn't it be?
It is randomized.
Yeah.
So now back to the invited group. We know the event rates among those non-attendees and attendees. And I presume, I think it's fair again, that those from the control group that would be presumed non-attendees, they would probably have the same event rate as those in the invited group not attending.
Because they're not getting the screening.
Yeah. So I think the event rate among our non-participants, it was quite high. It was 16% as far as I remember right now. I think it's fair to presume that the event rate in the presumed non-attendees in the control group would be 16% also.
Okay.
And then this is, and now we also know the number of events in our entire control group. And now we have got this simple equation with one unknown. So we can calculate how many events would the presumed attendees have, and we can then calculate their attendance rate. It is difficult to explain, but it is just one simple equation with a few assumptions.
You know the people who got screened in the invited group. What you don't know is the people in the control group who would have gone to screening but didn't get to go because they weren't invited. And then by subtraction, you figure out the event rate, and what was that?
So the event rate in this presumed attendees was 5.8%.
In the actual active arm of
It
that
was
screen?
0.9 lower. So the screening had an effect. We'll do this assumptions. The screening had an effect decreasing the all-cause mortality with 0.9%.
And that was significant.
It was.
So the screening works. Maybe.
Yeah, I'm concerned about being really sure about that. I think the calculations are pretty straightforward, but we did not do that study.
Let's say that we believe it's somewhat beneficial. Do you think that it works in Denmark because of the Denmark environment, but may not work in the U.S.? And the reason why I ask is because one of the headwinds, one of the oppositions for screening is harms from overzealous overtreatment and overdiagnosis, and perhaps there's less of that in Denmark than there would be in the U.S. system. What do you think of that?
I agree. The way we had this trial, there was not that much downstream testing at all. Actually, the hazard ratio of revascularization, cardiac revascularization, was 0.88. It was borderline significant, fewer revascularizations in our invited group. It was not the opposite. So there was a borderline significant reduced revascularization rate in our invited group.
So you screened people, figured out they had coronary disease, started secondary therapies like statins and lifestyle, but it did not lead to more intervention in terms of PCI or bypass.
No, for sure it did not.
And I think this is remarkable, and I think it's why this sort of screening would work in your system, but might be not so beneficial in ours.
I think you're right.
Thank you so much for talking to us, and thank you for doing this research and talking with us.